Hello, and welcome to Pop Talk Sessions, delivering high quality care for older adults. Good to see you again. I'm Jim Lawson, Manager of Outreach Development for ABC, and I have the honor of moderating today's discussion. America's population is aging rapidly. Look at me. And with it becomes a growing need to address mobility changes and challenges among older adults. It's increasingly important for healthcare systems and practitioners to adjust their care practices to meet these emerging demands. Today's continuing education course focuses on how the prosthetic, orthotic, and podorthic, POP for short, profession is evolving care practices and approaches to meet older adults' mobility needs. Now, today, our experts will discuss how healthcare systems are implementing age-friendly care models and innovating with new approaches to better serve aging populations. You'll learn about how the profession is prepared to care for older adults' needs in the decades ahead, plus practical tips to help you respond to your older patients' needs today. Now, before we start in, I have a few programming notes, a little housekeeping. We'll have plenty of time for Q&A, so please feel free to share your questions in the Q&A box throughout the discussion today. Now, today's discussions is the first series of 3 Pop Talks. The series is worth 3.75 Category 1 business CEUs, or credits as we call them, or 1.25 credits per session. So be sure to take the quiz after this course to earn your continuing education credits. A link will be provided to you in the chat and by email. Now with that, I'd like to introduce to you today our expert speakers. Heather Benzel is a health specialist, system specialist in the U.S. Department of Veteran Affairs. In her role at the VA, she works to advance access and quality of aging veteran services and guides the implementation of age-friendly health systems across 8 VA facilities. She's a nurse leader with 19 years of experience across clinical research, quality management, mental health, among many other specialties, and has served as many leadership roles across the VA since joining it in 2014. Now, our second expert, Jonas Ljung, is the Director of Clinical and Education Services at the National Commission on Orthotic and Prosthetic Education. Now, at NCOPE, he leads national academic and clinical education initiatives to strengthen the POP profession. Jonas brings more than a decade of clinical experience as a CPO, clinical manager, and residency director, and is passionate about improving training standards, integrating data-driven approaches to patient care, and educating the next generation of POP professionals. Heather and Jonas, thank you so much for being here. We are so pleased to have you so you can both share your expertise. So now I'm turning it over to Heather, who's going to talk about age-friendly care at the VA. Heather?
Great. Thanks, Jim. Well, good afternoon, good morning. Thank you so much for having me. Today, I'm going to tell you a little bit about the VA's journey to implementing age-friendly care. Next slide. I have no relationships to disclose, but I do want to thank the entire VA age-friendly team. Their incredible work not only contributed to this presentation, but to the VA's journey as a whole in transforming our healthcare system. As a reminder, this talk does not represent the official position of the U.S. government or the VA. Next slide. Why is healthy aging a priority in the VA? Our veteran population is aging, with more than half of those we serve now over 65. That's 4 million enrolled veterans age 65 and older. That makes healthy aging a core part of VA care, not just an add-on. Many veterans manage complex, chronic, or service-related conditions that can intensify as they age. So focusing on prevention, mobility, and overall function helps them stay independent longer. A proactive approach to healthy aging improves quality of life for veterans, reduces avoidable hospitalizations and long-term care needs for our system. Ultimately, investing in healthy aging is one of the most meaningful ways we honor our commitment to those who served. Next slide. In March of 2020, the VHA Office of Geriatrics and Extended Care set aim for the VA to become the largest integrated healthcare system to be recognized by the IHI as age-friendly. Next slide. So what is age-friendly health systems in the 4Ms? Age-friendly health systems are built around a simple evidence-based framework called the 4Ms. The idea is that every interaction with an older veteran should align with these 4 essential elements, practiced together as a set in any care setting. The first M is what matters, making sure care is guided by what matters most to the veteran, not the provider, including their goals and preferences. Next is medication, which focuses on using medications that support those goals while avoiding those that may cause harm. Mentation addresses cognitive health, including preventing, identifying, and managing issues like dementia, delirium, and depression. And finally, mobility centers on keeping veterans safely moving every day to maintain function and independence. Each M affects the others, which is why the 4 M's work best when they're assessed and acted on together. This framework helps ensure that all care we deliver is age-friendly, consistent, and responsive to the unique needs of older veterans. Next slide. This slide highlights recently published work by VA staff and clinicians, underscoring how committed our teams are to advancing age-friendly care. Their research shows how applying the 4 M's across the entire continuum, from outpatient visits to inpatient care, emergency departments, CLCs, and beyond, directly supports veterans' ability to maintain quality of life and age safely in place. The visual here demonstrates how integrating age-friendly practices at every touch point creates a smoother, more supportive experience for older veterans. This evidence helps validate what we see in practice. When we consistently use the 4 M's, we reduce harm, strengthen function, and better align care with what matters most. These studies not only guide our ongoing improvements, but help position VA as a national leader in age-friendly, veteran-centered care. Next slide. So how do we do it? The VA Action Community provides a structured 7-month pathway to help facilities move forward on their age-friendly journey. Teams start by learning the 4 M's framework, then participate in a half-day workshop, followed by monthly webinars and coaching calls, providing hands-on support. By month 7, facilities are prepared to earn IHI age-friendly recognition. Guiding more than 1,300 healthcare facilities through this process isn't easy, but the Action Community gives them a clear roadmap, shared learning, and consistent support to make age-friendly care a reality across the VA. Next slide. This slide highlights the achievements and recognition of age-friendly care throughout the VA as of February 1 of this year. The VA represents approximately 12% of all age-friendly health system recognitions, the most of any health system. 496 care settings across 164 VA facilities have earned that level 1 recognition. 325 of those have earned committed to care excellence. Next slide. So we needed a way to support our teams in this process. The dashboard pulls health factors, think data elements, from the National Age-Friendly 4 M's note template. As we scale age-friendly care across the VA, having a user-friendly documentation template is essential. The National 4 M's note template in CPRS, that's our VA medical record, gives staff a simple, consistent way to assess and record each of the 4 M's in any care setting. This helps teams build reliable workflows, track their progress, generate the data needed for IHI recognition. Just as importantly, the template allows us to identify which veterans are receiving age-friendly care and to monitor the outcomes associated with this model. By capturing these assessments in a standardized way, we can better understand where care is strong, where support is needed, and how the 4 M's are improving safety, function, and overall veteran experience across the system. Next slide. So where does all of this data go? Once the 4 M's are documented using the standardized national template, that information flows directly into the VA's age-friendly dashboard. This gives every facility a clear, real-time view of their age-friendly touches and assessments. The dashboard makes it easy for teams to monitor progress, spot gaps, and understand how consistently the 4 M's are being applied across the care settings. Having this national unified data source is essential for supporting facilities and their teams on this age-friendly journey and ensuring we're delivering reliable, veteran-centered care. Next slide. This study from the VA Skilled Nursing Facility in Boston shows how integrating the full 4 M's framework into daily practice can meaningfully improve outcomes for veterans. When the 4 M's were applied together as a coordinated model of care, The facility saw a reduction in falls, decreases in distressed behavior, and an increase in deprescribing events. These results highlight the power of using the 4Ms as a unified approach, not as separate activities, but as an integrated care model that supports safety, well-being, and overall quality of life for the veterans we serve. Next slide. This story is such a great reminder that age-friendly care isn't rocket science. It's about listening to what truly matters to a veteran and coordinating the right support around that goal. In this case, a CLC veteran at the Sioux Falls VA shared during his care plan meeting that his honor flight was coming up. This was a once-in-a-lifetime opportunity for him, something he dreamed about for years, and he was heartbroken at the thought he might not be able to go. The team knew there was no way he'd be discharged in time. So the team paused and said, okay, if this is what matters most, how do we make it happen? And that's where the 4Ms really came to life. They made small but thoughtful adjustments to his medications. They held Lasix so he could avoid needing to get up multiple times during the flight and preparing medication boxes to take with him. They prepared mobility equipment he'd need for a long travel day, swapping out his bulky equipment for portable, lightweight walker and wheelchair. They focused therapy 2 weeks beforehand on building his strength to successfully complete the needed transfers during the trip. They coordinated transportation, planned for comfort, and supported his mood and confidence as the trip approached. None of these steps were complicated on their own, but together they removed the barrier standing between him and something incredibly meaningful. And because of that coordinated effort, he made the honor flight, returning with a huge smile and a renewed sense of purpose, which carried over to his motivation for recovery during the duration of his inpatient stay. This story shows that age-friendly care really is small, intentional actions centered around what matters most to the veteran, and the impact can be absolutely life-changing. Next slide. As I wrap up, this slide is just a great reminder that aging isn't just about caring for older adults. It's about every single one of us. Every veteran, every patient, staff member, everyone on this call is on the same journey. Age-friendly care isn't a niche initiative. It's a commitment to making our systems supportive, safe, and responsive for all of us as we grow older. When we get this right for our veterans, we're also building a better model of care for our own future selves. Thank you.
Heather, thank you so much. Great information, wonderful information. We're going to dig a little more into that in a little while with some questions. Thank you for sharing that story also. Excellent, excellent. All right, Jonas, you're up to bat now. Over to you. Are you ready?
Thanks so much, Jim. So working with students and residents at NCOPE has always got me thinking about what I wish I knew earlier in my career. Not necessarily a new material, not a new component or device, but better ways to organize my thinking, which I feel is especially relevant when it comes to working with older adults. Looking back, I realize I was often doing the right things, at least I hope I was, but maybe not with intention and structure. What I wanted to share today is an application of the 4Ms framework that gives structure to things many of us already do intuitively, to help make aging adult care more consistent, safer, and more patient-centered. Next slide. Heather already provided a great overview of the VA's approach to age-friendly health systems and the 4Ms framework, so hopefully I will not repeat her too much. Obviously, age-friendly health systems and the 4Ms framework is about encompassing all the aspects of care on a systems or macro level. But my job for the next 10 minutes is simple, to relate the 4Ms directly to orthotics and prosthetics, and how we can utilize the framework to enhance the way we evaluate, design, deliver, and follow up with our older adult patients on a more micro level or a more personal level. Looking back at my 15 years of patient care, if I was able to apply the 4Ms framework this way, both methodically and deliberately, I believe many of those challenging aging adult cases would have been made easier if I hadn't just missed one of the M's. Next slide. So let's start with the first M, what matters. In the 4Ms, what matters is about aligning care with the older adult's goals and preferences, not necessarily our default goals. So here's an O&P truth. we're trained from school to the clinic to think in terms of diagnoses and devices. And the 4Ms asks us to think in terms of life goals. With older adults, success is rarely just, I want to walk better. In reality, it's more like, I want to get to the bathroom at night without falling. I want to stand long enough to cook dinner for my family. I want to be able to go to church again without being pushed down the aisle in a wheelchair. If we don't ask our patients what their goals are and how they will measure their own successes, we risk designing and delivering the right device for the wrong outcome. Two patients can walk into your clinic with a diagnosis of diabetic neuropathy, foot drop, and a history of skin breakdown. Both have a prescription for a custom AFO. So same diagnosis, same prescription. But what matters might be different. One patient may want to be able to safely walk outside and maintain their independence. So maybe we're fitting this patient with a dynamic energy storing AFO, multiple heel wedges for different shoes, referring them to physical therapy, and scheduling follow-ups every 3 months to check for adverse skin issues due to motion. The other patient wants to transfer safely at home and reduce their fear of falling. So maybe we're fitting this patient with a solid ankle AFO for maximum stability, teaching their caregiver to regularly check their skin, and following up once a year to ensure the integrity of the orthosis and to change the straps. So same problem list, but totally different design priorities, training plan, and follow-up. Here's the practice change we can make, and it's tiny. Add one sentence to every evaluation and document it. What are you hoping this device helps you do that you can't do now? Then, at your follow-up, judge your successes against that. Don't just ask the patient, are you having any rubbing, or are you wearing it? If we don't define what matters, we end up optimizing the device and not the patient's life. Next slide. The 4Ms calls out that medications can impact older adults in ways that affect function and safety, and it can even interfere with the next two Ms, mentation and mobility. Now, obviously, we don't prescribe meds in O&P, but medications absolutely affect our treatments and show up in our outcomes. Here's some medication-related patterns most of us see when we treat older adults, even if we don't label them that way. Dizziness or sedation. Patients are at a higher fall risk when they're learning to use a new device, so additional external factors must be considered. Neuropathy management. Changes in pain perception can change how quickly skin issues are noticed. Blood thinners. Bruising or skin fragility can quickly become fit and tolerance issues. Long-term steroid use. Similarly, tissue tolerance and healing risk associated with steroid use can change what acceptable pressure is. In this case, let's think about an older patient who falls after being fit with a new prosthesis. We could spend weeks and multiple appointments in the parallel bars, tweaking and adjusting their alignment, when the real change was actually a new sleep medication which made them lightheaded and dizzy whenever they transitioned from sitting to standing. Here's the practice change. 2 questions. At every appointment, ask, have there been any medication changes in the last month? And have you experienced any new dizziness, sleepiness, or balance issues? If they say yes, you don't need to panic, just adjust. Slow the progression, reinforce assistive device use, consider PT or OT collaboration, and tighten your follow-up schedule. Medication doesn't live outside our scope. It lives inside our safety plan. Next slide. Mentation, our patient's mind and mood. The framework emphasizes paying attention to cognition, mood, and changes that can affect outcomes. In O&P, mentation shows up as a patient not remembering how to don or doff, not reporting skin issues until they're too severe, or not wearing a device leading us to think they must be non-compliant. But a lot of that isn't necessarily non-compliance. It's a mismatch between cognitive load and what we fit them with. I think we've all seen it. An older adult with a history of stroke, mild cognitive impairment, and depression. We deliver an orthosis with multiple steps, multiple straps, and a complex break-in schedule. They nod in clinic, and then when they get home, it all falls apart, figuratively and sometimes literally. That's not a bad patient. It's a design and training miss. So here's the 3rd M practice change. You can try using a teach-back method at every delivery. Instead of us asking the question, do you understand? Instead, say, show me how you're going to put this on when you get home. If they can't demonstrate it, it's not a failure. It's just more information. Then we have options. We could simplify the orthosis, simplify the routine, involve a caregiver, provide written or visual steps, or schedule more frequent follow-ups. Mentation isn't a label, it's a design constraint we have to consider for every patient. Next slide. Mobility emphasizes keeping older adults moving safely because it supports function and helps them do what matters. Obviously, at its core, O&P is built around mobility, right? But the 4Ms framework pushes us to go beyond my patient walked 50 feet in the clinic, because clinic walking is not real-life mobility. Real-life mobility is uneven thresholds. It's crossing the street when the red hand is blinking. It's bathroom trips in the middle of the night, changing shoes depending on the outfit you're wearing, carrying groceries, or fatigue. A prosthesis can be beautifully aligned, and an AFO can be perfectly tuned. But if we didn't address transfer strategy, footwear, and assistive device integration, mobility risk can stay high. So here's a practice consideration for the 4th M, a 30-second mobility safety check at every delivery. Ask 3 quick questions. What's the first thing you're going to do when you get home? What shoes are you planning to wear with this? What assistive device are you using and when? And then set a safe accommodation plan accordingly. If your patient has a fall history, dizziness, or major mobility change, normalize collaboration. Tell them, let's pull in PT, or let's coordinate with OT. The referral pathway outside our profession is risk management and quality improvement. It's not extra work. Mobility doesn't start at the parallel bars. It starts when the patient gets home. Next slide. Now here's the part I want you to take home. The 4Ms work best as a single mental checklist you can apply to every older patient interaction. The age-friendly health system's goal is reliably providing the 4Ms to all older adults every time. So to review, here's the O&P version. What matters? What are your patient's specific goals with their orthosis or prosthesis? Medication. Have there been any changes that may affect safety, skin integrity, or balance? Mentation. Can your patient learn, remember, and report issues, and do we need caregiver support? Mobility. Is this O&P treatment safe for their environment, given factors such as their footwear choices and assistive device plan? If you can answer those 4, your treatment choices get sharper, your training gets more effective, your follow-ups get easier, and ultimately your patient outcomes improve. So let me close with one simple challenge. If you're a clinician, I want you to pick one M to strengthen this week. And if you don't know where to start, why not start with the first one? What matters? Ask the question and document it. By making a small system change like adding a what matters or goal setting prompt to your evaluation, or maybe adding a teach back checkbox at delivery, you can dramatically increase the effectiveness of your treatments. If you're a student or resident, be mindful of the 4Ms framework whenever you're in front of an aging adult and integrate it into your daily interactions. If you build the habits early in your O&P career journey, it's going to elevate your care and outcomes for your patients in the future. The 4Ms aren't about doing more, they're about doing what matters better. That's all I've got. Thank you.
Jonas, thank you so much. That is great. Both you and Heather did a fantastic job. Now, before we open up to questions from the attendees in the audience here, I have a few questions I'd like to ask Heather and Jonas, and I'm allowed to do that because I'm the moderator. Anyway, Heather, now you had told us the story about the gentleman who was taking the flight to DC. We understand that story. Could you talk a little bit more about how age-friendly care can be applied to specific care settings? Do you have anything further on that?
Sure. So every care setting looks a little bit different. Every facility that implements this looks different. But for example, we have some age-friendly care settings in an ER. Now imagine an emergency room and stopping to look at what your age-friendly healthcare looks like. Oftentimes they'll have what they call age-friendly carts. So these are carts with things like pocket talkers if they have a hearing disability, or readers, things that they might have forgotten at home as they came into the ER. One of the number 1 causes of delirium is hearing loss. So imagine being scared and nervous and in an ER needing to get to a root core of a problem, but you have all of these things in the way. Oftentimes ERs that are looking at age-friendly health systems have a PT or an OT on staff. They're there to address things that might need to be shifted a little bit before that person is discharged. In a long-term care setting, we talked a little bit about that, but sometimes they're looking at fall reduction. Sometimes they're just looking at safety. When we get to home settings, sometimes we're looking at more rehab. How do we keep them home for as long as possible? And sometimes they just come in and they want to talk about, how do I stay healthy enough to go to my granddaughter's wedding? We had one very specific case where they came in to an outpatient clinic, and as they were asking them about what matters to this veteran with dementia, the wife said the only thing that brings him joy is going out to eat, and we can't go out to eat. And the clinician said, why can't you go out to eat? Well, he's been incontinent and he's too embarrassed, and it's too difficult once we get out there. And so they stopped and said, okay, hold on, we got to look at this. The wife said, and his medications are so expensive that it's becoming problematic to go out to eat. So they looked at his medication list, and he had some medications that the side effects were incontinence. He had some medications that had generics available, but the bill burden of what they were getting was huge. And the clinician said, oh my goodness, we can fix this today. They made a couple medication changes. Within a week, he was going out to eat again. Like I said, it's not rocket science, but it's really looking at what's important to that patient and their family, rather than what sometimes are the priorities of clinicians.
Certainly, certainly. Jonas said a word before. He was going to say the word patient, but he said parent. I don't think that was a mistake. I think if we're looking as clinicians, we look at these patients as, let's put our parents in this position. And man, that opens up everyone's thought process. So speaking of that, Jonas, okay, for those practices that maybe aren't using the 4Ms yet, okay, what do you see as the biggest barriers and opportunities to implementing the 4Ms framework in O&P clinics, those clinics, either large clinics or small clinics?
Wow. Okay. Let me think. I'll start with the opportunities. So based on CMS Medicare utilization data, it's estimated that roughly 2/3 of orthotic and prosthetic care serves older adults.
Right, right.
So that's a huge percentage of what we see in the clinic on a day-to-day basis. So I think that the impact that something like the 4Ms framework can have on clinical practice is large, obviously, 2/3. One of the challenges implementing it, I believe, is kind of the fact that the framework is designed for large healthcare systems like the VA. And, as a clinician, it may not seem applicable or translatable to a single clinician in a single specialty.
Right.
But I mean, hopefully I did a decent job of illustrating how adding just a few simple questions to patient interactions or parent interactions can be an effective application of the 4Ms concepts on an individual level.
Okay, excellent. Now, you both talk about age-friendly health systems model, how it benefits the patients. We know that. We get that. Heather, can you talk a little bit more how it impacts the clinicians?
Yeah. So Jonas, you said something, and I had to write it down because it was brilliant. Stop thinking in devices and diagnoses, right? So we had the opportunity to spread age-friendly in our region. And after we got going, we said, we really want to figure out how this is working and what the impact has been. And so we met very specifically with each team. And one of the things I heard the most, that I would say I was surprised the most, we knew this was great for patients, was that clinicians said, I had one geriatrician that said, I was reminded why I became a geriatrician. I thought that I believed in this philosophy, but I realized I wasn't intentionally practicing it like I thought I was. We had somebody else that said the patient became a person, not just a name. And as a result, because I think especially, as healthcare clinicians, we get into that rhythm, right? We're here, this is what we got to do. Every day there's more pressure to be productive and efficient. And so sometimes we forget what that looks like when we stop and look at the person in front of us as a person with needs and wants. But we really saw staff say, this increased our job satisfaction. It gave us a sense of purpose that we didn't have before, or that maybe we had lost. I think especially after COVID, things shifted so much and we lost a little bit of that. And so it's actually increased that satisfaction and the retention of those staff members in the care settings that are employing this, which has been beautiful to witness.
Heather, I love hearing that. That is great. That is awesome. Jonas, let me ask you this. Have you seen a mindset shift among pop professionals who are implementing this approach? Have you seen anything?
I do think there has been a significant mindset shift in our entire profession. I think some of it comes from a change in the way orthotics and prosthetics is being taught to students, kind of with an increased emphasis on soft skills like communication and empathy with patients, I think, which go a long way, especially with aging adults. Um, while other changes are born from necessity, like an increase in collection of patient outcomes to validate reimbursement from payers like Medicare. Uh, Regardless, I think implementing strategies like the 4Ms kind of reinforces and makes these changes more second nature to us as clinicians, and really becomes an integral part of enhanced patient care.
Very good, very good. So one more question for both of you before we open up to the audience questions. Um, I have one last question here for both of you here. Can you both talk about the role of collaboration? I'm going to start with you, Jonas. How can pop professionals collaborate with other care providers like physical therapists, rehab specialists, et cetera, in those areas when it comes to the 4Ms? How can they work together to deliver the best patient experiences and outcomes?
Sure. As I had mentioned probably a couple dozen times before already, the 4Ms framework was sort of designed for healthcare systems, right? So I think as a result, collaboration between other professions in rehab is both inherent and necessary. Through adoption of the 4Ms, I'd hope that we as clinicians become more familiar with the process of constant collaboration and communication with our patients, PTs, OTs, with our physicians, nurses, et cetera.
Sure.
At a certain point, there's only so much like an orthosis or prosthesis can physically do. And the only way to advance the outcomes for our patients is through the involvement of all the relevant members of a patient's care network.
Okay, very good. And Heather, the VA's perspective, how does collaboration play out at the VA among health system leaders and practitioners?
Great question. So I think we're really lucky because the VA has so many interdisciplinary systems of care. So we have polytrauma systems of care where it's always an IDT team. We have our spinal cord injury and disorder. There's always that IDT team. So I think we're seeing a lot of best practices surrounding that IDT, which is really what the 4Ms looks at. You don't have to be the expert, but like Jonas highlighted in his presentation, being able to just identify when something feels off. You don't need to know what the medication means or how it needs to be corrected, but knowing that it's new and knowing that it could impact it is a huge part. And having that comfort of, it's a little too easy to get healthcare these days in different places. And so when you've got people going to multiple different systems, it becomes harder and harder to do that collaboration. So understanding where the patient in front of you is seeking those other healthcare needs, I think really allows you to say, okay, let's make sure we contact your primary care provider. Let's make sure we contact the rehab provider you're working with. We're really lucky in the VA, even when the patients go to the community for prosthetics, they'll call their clinician and say, hey, can we video chat? I want to make sure that we're talking about the right things at the right time and doing what we need to for them. So I think just constantly working to bring in all of those partners in their healthcare team is beneficial.
Very, very good. Thank you both. I appreciate this. And now we have time for Q&A from our attendees here. So if you have a question, please go ahead and use the Q&A function at the bottom of your screen. We have some questions coming in already. I'll start with the first question here. Let's see. Heather, this is for you. An attendee wants to know, how do I know or what do I need to look for to see if a hospital or care setting is age-friendly certified?
That's a great question. In the VA, I can tell you we keep our own dashboard because I have the same question. Every time somebody gets recognition, I have to go and try to find it. And everybody does it differently. So we have some that really wear it on their sleeves. Maybe you'll see a sign that says we're age friendly. We're going to see it more in hospitals. It's part of CMS reimbursement now. And so I think we're going to see some of that marketing. But if they do it differently, some clinicians say, I'm going to get recognition and I'm just going to do it by chart review and show all the ways that our system is doing the 4Ms. Others have really embedded it into their culture. So I think it's safe to ask. I think you have to ask the question. It's by care setting, not facility. So you might walk into a hospital system and say, are you age friendly? And they might not know what you're talking about, but their ICU might know what you're talking about, or their ER. And so I think we still have some work to do on how to market that. Even in the VA, I don't think we market that we're doing age friendly as much, but I think we're going to see more of that come. But I would challenge you to ask your own clinicians or the clinicians for your loved ones, especially your parents, are you practicing age-friendly health systems? Because I think we need to be accountable and hold each other accountable for that level of care.
Very, very good. Very good. Okay, Jonas, here's a question for you. Oh, this is a great question. A POP professional wants to know, how can the principles from the 4Ms be applied to the care of non-elderly POP patients?
I mean, I think that the basic concepts are there within the framework. You know, trying to shift to a very patient-oriented goal setting with that first what matters. You know, maybe when it comes to a pediatric patient or something like that, maybe mobility isn't as much a concern. Maybe it is, maybe it's not. But you know, kids can fall and smash their heads and get up and keep running. So fall risk is not as big a concern as it is for our aging adult patients. But I mean, I think applying just a structured framework to any patient interaction where we're making sure we're following these certain steps and asking these certain questions is really going to sort of elevate the care in orthotics and prosthetics we can bring to all our patients. And maybe not exactly the 4Ms framework, but I think it's a good starting point for interactions with any patient.
Very good, very good. Okay, here's a question. This one's for Heather. What other tools, and I love the way this is written, what other tools and resources do you recommend to get smart on age-friendly care and the 4Ms framework? Let's get smart.
Oh, that's great. You know, age-friendly through the IHI is a huge system. They have a very large online presence. You can go out, you can Google it, you can look it up on your own. That'll really tell you. But I would also tell you that once you start the process, they're very good at mentoring sites. And so they're actually the best resource, the IHI, unless you're part of the VA, then the VA has age-friendly subject matter experts for you. But the IHI actually does a lot of that mentoring one-on-one to help you. When it comes to the concepts, I would tell you not to overthink it too much either. I think there's lots of people who think this is going to be really hard. And then when we get started, they go, well, that wasn't hard at all. I just had to realize how to do it intentionally. So I would reach out to IHI's resources. They have really great subject matter experts that will work with people one-on-one, and most of that is publicly available.
Excellent, excellent. Here's a little longer question. Sanja asks, can the 4Ms framework be applied outside the VA system, obviously for Heather there, particularly for older adults in geriatric settings? Also, age mental capabilities, mobility issues, and medications do not always match in predictable manner, where older means more issues. Should not all clinical personnel be mindful of the 4Ms? I know we don't know the answer for that. Yeah.
Yeah, I love that question. So the VA did not create age-friendly. We just wanted to be the biggest, best at it, I think really is the ultimate answer there. And so this lives in places outside of the VA. It happened outside of the VA first. So you can find it in a lot of facilities. We're going to find it in a lot of hospital settings with the new CMS regulations that came out in 2025. So it's not just in the VA. And you're absolutely right. Patient-centered care is not new. That's what we've been trying. That's a high reliability organization. You know, that's something that we've been really trying to implement in all healthcare settings over the last few years. So patient-centered care really is what this is, but it's still a mind shift from clinician-centered care, right? What I think you need versus what you think you need. Now, obviously, that's different from pediatrics. My 7-year-old has no idea what he needs. He doesn't get to be in charge there. Right. But yes, looking at what the patient needs and wants and looking at those 3Ms that impact it, I think can be applied to anyone. When we first started this journey, we got really held up on, well, what do we do if we have a patient under 65 that comes into this care setting? And for me, it was really distressing. Like, do we treat them differently? And finally, we kind of decided, no, these are great principles for everybody. We just know our aging population is more at risk from negative outcomes of not doing this. So I think it's safe to say you can apply these concepts to any patient you see in front of you.
Excellent, excellent. Now, Larry has a question. Let's see here. Pull it up here a little bit. Here we go. Larry's question about the second M, medication. All right. He says he has found some of his patients he sees have issues that usually point to dehydration and a cause for a whole new range of issues caused by one medication or a combination of medications. Larry's question is basically this: is it my job to consult on the issue as an orthotist? Both of you can answer that. Jonas, what do you think?
I think without knowing a specific example, I would say it's probably your job to have a conversation with other members of this patient's healthcare network.
Yes.
Reach out to their physician and say, so I noticed this patient is having trouble with dehydration and it's resulting in these, clinical issues with the fit of their orthosis. Maybe it's too loose causing rubbing or something like that, hypothetically. And then I think that really comes back to that communication aspect of the age-friendly system and the 4Ms as well, that it's not just about what you're doing individually with the patients, but it encompasses the entire continuum of that patient's care.
Yes, Jonas, and you used the word communication. How important is that? Heather, do you have anything to add to that?
The only thing I would say is, we all know white coat syndrome, right? When your blood pressure increases when you're in front of your clinician, but at home, it's totally normal. And so I think it's really the job of every healthcare discipline to advocate for your patient. It doesn't have to be your specialty. You don't have to be the expert on their medication. You don't have to, I'm a nurse. I'm not an expert on mobility, but I can identify when something's off, when something's not right. And I think it's all of our responsibility to contact the appropriate person. So don't put the pressure on yourself to fix it, but do be mindful of who their team is. And when something feels off, who can I reach out to? That's the piece I think is the most important.
Great answer, both of you. We have a question from Liv. How do you recommend keeping track of age-friendly outcomes at the individual practitioner level?
It's a great question.
Yeah. Do you want to jump in, Heather?
Heather, what are you doing at the VA with that?
Sorry.
Well, it's a little easier for us because we have data systems that we collect this.
Okay.
So, but we had to set that up ahead of time. And as we're transitioning to a new electronic health record, we have some anxiety about how we're going to keep being able to track that. And so I think from smaller systems, depending on what your medical records show, that can be really difficult. But I would say just being able to really show what teams are using age-friendly practices, if there's certain clinicians that are using age-friendly practices, anything you can do if you have an electronic medical record and you can somehow flag that they have what matters, or you have those IDT meetings, any piece of that is really important, but you're not wrong. It's really difficult, especially if we don't get into the habit of documenting specifically the age-friendly care that we give. So if you're the clinician and every time you see them, you start your note with what matters, it's a lot easier to go back and see what everybody else said matters to them at that visit too. So a lot of it's documentation, but it does get difficult depending on the system you're in.
Excellent. Jonas, any thoughts on that?
Yeah, just to kind of piggyback on what Heather was saying, I think it is a challenge. Some people work for larger O&P organizations, companies that may have more resources and are tracking outcomes over a national patient population or something like that, where I think it becomes a little bit easier to see what impacts changes or implementing the 4Ms might make. Are for smaller companies, smaller clinics with fewer resources and just fewer patients in general, I think it becomes a little bit more difficult to actually quantify what effects you're having. That being said, I do think there is a lot of value to the sort of anecdotal evidence. And I think to that the first M, that what matters, and goal setting. If you're actually doing a goal setting exercise and asking your patients what matter at every appointment, and then at the follow-ups, asking them, are we meeting your goals? And if they say yes, I think that framework is making a difference. And if they say no, that doesn't mean the framework's not making a difference. That just means you've caught it, and now you can adjust your care plan to reflect that and hopefully meet their goal for the next appointment.
Excellent, excellent. Jonas, question for you here. The reason for you is because this deals with our excellent master's programs here. How are prosthetic and orthotic and podorthic, actually podorthic also, educational programs integrating this framework into curriculum? Have you seen that? Are they working in that direction?
I can't speak to that. I mean, every program has its own curriculum, and unfortunately, I don't know what's being taught in all of them. I do know that with the transition to the master's program, there has been an increased emphasis put on clinical skills versus, hand skills or fabrication or things like that. And involved with those clinical skills are patient interaction, ability to take notes and document, as well as, patient empathy, forming personal connections with your patients for more effective communication and things like that. So I think whether that might not reflect necessarily the 4Ms officially, I think many of the concepts in there, play hand in hand and complement 4Ms structure very well. So even if you're not being taught it explicitly in a master's program, I think application of the framework is almost second nature once you get out into clinical practice.
Very good. And as they're getting their clinicals while they're at school and moving into residencies, they should be getting this hands-on with that. Excellent point. Excellent point. We're just about out of time for questions, but we have one more here. As an employer, what advice can you share to help me implement age-friendly care and the 4Ms framework across my organization? Let's see, this popped up there. Where should I begin? Let's start with Jonas and then Heather, if you want to join in.
Yeah, I think the simplest one, with more and more practices moving towards, electronic health records or electronic medical records, I think a lot more of the standard of care is coming from evaluation templates and things like that to ensure that we're checking all the boxes, hopefully not literally, but hitting all the important points when it comes to the important information we need from our patients, the information we need for reimbursement, and things like that within the evaluation. So adding questions relating to the 4Ms, or even taking the 4M template that Heather had in her presentation and integrating that into your evaluation templates, I think is a very intuitive way for every clinician in your company as an employer to start instituting these by asking the questions that are in front of them, honestly.
Very good. Heather, any thoughts?
My only thought, those were great logistics. When we started in the VA, we really focused in on those who maybe already supported the philosophy of the 4M. So as an employer, I'd be looking for those pockets of champions that you have, and start small. You need a couple people on the front line to really implement and go, oh, that wasn't hard at all. Actually, it was great. And here's why it was so easy. And so I always tell people, look for those really enthusiastic, sometimes those of us that can be a little bit louder to do that implementation, because they're the ones that are going to get everybody else excited about it.
And share that message also. Excellent, excellent. Okay, one more final question. I promise you this time, okay? How about a down to basics question? This is very elementary. This is great. Before we conclude, how do we get started? Heather, Jonas, I'd love to hear from both of you on that. How do we get started with this?
Yeah, I would say the first thing you do is you get online or through your organization to figure out if you have any age-friendly health system resources available. Otherwise, get online. Google age-friendly health systems will really give you the tools that you need. What do you need for level 1 recognition? It's very simple. It's just creating a plan that you submit to the IHI and they approve it. And then getting that level 2 recognition is just gathering 3 months of data. So that process is very simple. I think you start looking into it and you get connected with either, if you're in the VA or you have an age-friendly group within your organization, get connected with them. Otherwise, you go right online and reach out to IHI directly.
Great.
Yeah, and on an individual clinic level, once you've done your research and collected all the information, just applying it to your everyday practice in all your patient interactions. I would love to get to the point, even if your facility isn't labeled as having a part of the age-friendly system. I think just it enhances patient care to utilize this framework, this structure, way of thinking about it and communicating with our patients. I would love to get to the point where we're interacting with our patients and we ask them about our medications, and they say, they didn't ask me that at my last medical appointment or something like that.
Huh.
That it just becomes so second nature that it's the expectation of our aging patients to understand that these questions should be asked and to expect to answer them at every appointment.
Very good, very good. So as we come to the close of this session, I want to extend a big, huge thank you to Heather and Jonas. Both of you, thank you so much for sharing your expertise and your insight. Couldn't have done it without you. We thank you so much. But we also want to thank all of you, all of our attendees, for participating in this discussion. Now, as I mentioned before, there's a link to carry a survey to go ahead to that survey. It's now in the chat room. Please feel free to share your feedback. We'd love to hear what you thought about this session today. We'll share a link to the recording and the slides and the CE quiz tomorrow. Now, the CE continuing education quiz for the units itself link is also available in the chat. This Pop Talk is the first, as I mentioned before, of a series of 3 Pop Talks this month, in Pop Month, March. This next is Thursday, March 19th at 12 p.m. Eastern Standard Time, Mobilizing AI for Pop. Huge topic, mobilizing AI for POP. I know you want to be in there for that next Thursday. And the final talk will be on Thursday, March 26th, the Thursday afterwards at 12 noon Eastern Standard Time, prioritizing the wellness of your team. Now, we know if you're not healthy, your team's not healthy, you can't do well taking care of others. So that's extremely important also. We hope you log on for both of those. Please go ahead and register for both of those. There's a link in this chat to register for both of them. Now, we hope you join us and you invite other colleagues to join us for those next Pop Talks. They're going to be great. We have wonderful guests and expertise on that also. Again, from ABC and for Pop Month, we thank you so much and we hope you have a wonderful day. Take care.